Hello friends, this is Dr. Chandan Mohanty and today I have come up with an interesting and important topic of biopharmaceutics and pharmacokinetics, that is non-linear pharmacokinetics. In this part 1 of video, I will be discussing about these points. First one, the introduction. What is non-linear pharmacokinetics? What are its other names and why they are called by these names? We will discuss. Then second, Michaelis-Menten equation. What is Michaelis-Menten equation and what is the plot of Michaelis-Menten equation? We will discuss. Then third, what are the various differences between linear and non-linear pharmacokinetics? Then how this non-linearity can be detected? Then last, what are the various causes of non-linearity? So let's start. Non-linear pharmacokinetics are also called as mixed order kinetics, capacity limited kinetics, dose dependent kinetics, and Michaelis-Menten kinetics. Why? We will discuss one by one. So we know there are drug ADME, means absorption, distribution, metabolism, and drug excretion. So generally these ADME, they will follow first order kinetics. First order kinetics means the rate process of this ADME, they will be depending upon the drug concentration. When the drug concentration will increase, the rate process also will increase simultaneously. So if you will see this graph, this plot is between the concentration of drug and rate of drug absorption. So here two lines are there. One line is for passive diffusion and one line is for carrier mediated transport. In carrier mediated transport system, the drug absorption is done by some carriers, but in passive diffusion process, this process will happen automatically. We don't require any carriers here. So if you see this graph, this passive diffusion is linear, means as the drug concentration is increasing, the rate of the drug absorption also will increase simultaneously. But in case of carrier mediated transport system, the graph will increase up to a certain point, then it will become constant. So when these carriers are get saturated, from that point this rate process will go on at a constant rate. Initially the rate will increase up to a point till the carriers are not saturated. When these carriers are get saturated, it will proceed at a constant rate. So this passive diffusion, it is linear, but in this carrier mediated transport, first it will be linear, then followed by at a constant rate. So this is linear kinetics, this is non-linear kinetics. Why it is called mixed order kinetics? Because here in case of carrier mediated transport system, when this ADME process is depending upon some enzymes or carriers at high dose, at multiple dose, it will not follow linear pharmacokinetics. Here we will see the mixture of both first order and zero order kinetics. Generally ADME process, they will follow first order kinetics, but here when these ADME process are depending upon some enzymes or carriers, they will follow mixture of first order and zero order kinetics. Hence it is called as mixed order kinetics. Then why it is called non-linear pharmacokinetics? Because there is deviation from originally linear pharmacokinetic profile. It should be linear, but in these cases, in these special cases, when this process is depending upon some enzymes or carriers, it will be not linear. Hence it is called non-linear pharmacokinetics. And why it is called capacity limited kinetics? Because this non-linear pharmacokinetics is observed when the ADME process are depending upon some enzymes or carriers. These enzymes and carriers are having certain capacity. Beyond that they cannot work, they will become saturated. So as they are having some capacity, it is called as capacity limited kinetics. Then why it is called dose dependent kinetics? Because at high dose, at multiple dose, we will see this non-linear pharmacokinetics. This non-linear pharmacokinetic profile will be observed at high dose or at multiple dose. Hence, it is called as dose dependent kinetics. Then why it is called Michaelis-Menten kinetics? Because these non-linear pharmacokinetics are best explained by this Michaelis-Menten equation. Hence, it is called as Michaelis-Menten kinetics. So these are all the other names of non-linear pharmacokinetics: mixed order kinetics, capacity limited kinetics, dose dependent kinetics, and Michaelis-Menten kinetics. Michaelis-Menten equation. As I told, nonlinear pharmacokinetics are also called as Michaelis-Menten kinetics because these nonlinear pharmacokinetics are best explained by this Michaelis-Menten equation. Then what is this equation? This equation is minus dc by dt is equal to Vmax into C divided by Km plus C, minus dc by dt is equal to Vmax C by Km plus C, where minus dc by dt is rate of decline of drug concentration with time t, Vmax theoretical maximum rate of the process, C as you know plasma drug concentration, and Km Michaelis-Menten constant. So this equation is Michaelis-Menten equation. Michaelis-Menten equation plot. So this is the plot for Michaelis-Menten equation. This graph is plotted between C versus dc by dt. C we know plasma drug concentration, and this dc by dt is the rate of elimination. So if we will plot a graph between C versus dc by dt, the graph will be like this. Initially it will increase, then it will become constant. At low dose it will follow first order rate. When the dose will be increasing at high dose, it will follow zero order rate, but at intermediate dose it will follow mixed order rate, means neither first order nor zero order. So this graph is initially the rate will increase, it will follow first order with the concentration. When the concentration will increase slowly, it will follow first order at low dose, and it will become mixed order at higher concentration. When the dose will increase, then it will start following mixed order kinetics, and then it will reach maximum Vmax. Vmax is theoretical maximum rate of the process, and beyond that it will go on at a constant rate, means it will follow zero order. So beyond this point it will follow zero order and it will proceed at a constant rate. So this graph is Michaelis-Menten plot. This it is plotted between C versus dc by dt, first order at low dose, mixed order at intermediate dose, and zero order at high dose. Difference between linear and non-linear pharmacokinetics. Here 4 points are there. In case of linear pharmacokinetics, the rate process of ADME are not depending upon the carriers or enzyme. Here, the carriers or enzymes are not involved in the ADME. But here in non-linear pharmacokinetics, the rate process of ADME will be depending upon the enzymes and carriers. When these enzymes and carriers are saturated, at that point we will see this non-linear pharmacokinetics. Then second point, in case of linear pharmacokinetics, the change in the plasma concentration due to this ADME process is directly proportional to the dose of the drug administered. But here, in case of non-linear pharmacokinetics, the change in the concentration of a drug is no more proportional to the dose of the drug administered. Third point, the linear pharmacokinetic, it will follow first order kinetics. Here we will see the rate process of ADME, they will follow first order kinetics. Means with increase in the drug concentration, the rate process of ADME also will increase simultaneously. But in case of non-linear pharmacokinetics, the first order process will be changing into the mixture of first order and zero order process. Means the original first order profile will be changed into the mixture of first order and zero order. Hence it is called as mixed order kinetics. Then last point, no change in pharmacokinetic parameters. In case of linear pharmacokinetics, the pharmacokinetic parameters like F, Ka, Ke, Vd, clearance means bioavailable fraction, absorption rate constant, elimination rate constant, volume of distribution and clearance. These parameters will not change. But in nonlinear pharmacokinetics, the pharmacokinetic parameters will change with the administered dose. So these are the differences between linear and non-linear pharmacokinetics. Detection of non-linearity. The nonlinearity can be detected by two ways. Number one, determination of steady-state plasma concentration at different doses. Number two, the determination of some important pharmacokinetic parameters like F, T half, Cl. So first is detection of steady-state plasma concentration at different doses. If the steady-state plasma concentration is directly proportional to the dose, that means it is linear pharmacokinetics. And if the steady-state plasma concentration is not proportional to the dose of the drug, then it is following non-linear pharmacokinetics. So if the plasma drug steady-state concentration is not proportional to the dose, it is indicating that it is following non-linear pharmacokinetics. Then second method, by calculating some important pharmacokinetic parameters like F, bioavailable fraction, the elimination half-life T half, and total systemic clearance Cl. Generally these parameters are constant. If there is any changes in these parameters, that means there is non-linearity in pharmacokinetics. So if these parameters are changing, it is indicating that there is non-linearity. Causes of non-linearity in absorption, distribution, metabolism and excretion. ADME. First, drug absorption. When the drug absorption is solubility or dissolution rate limited. Example, the drug griseofulvin. Sometimes the drugs will be slowly dissolved. So in those cases, the absorption is dissolution rate limited, and in those cases there will be non-linearity will be observed. Then second, when the drug absorption is depending upon some carriers, when the absorption involves carrier mediated transport system. So when these carriers will become saturated, then we will see this non-linearity. Example, riboflavin and ascorbic acid. Then third point, hepatic metabolism attains saturation. When the pre-systemic hepatic fast pass metabolism will attain saturation, then we will see. Example, propranolol. Then in case of drug distribution, 2 points are there. When there is saturation of these binding sites, number one, the saturation of binding sites on the plasma protein, example phenyl butazone, and second, the saturation of tissue binding sites. So when both these binding sites are get saturated, then we will see the non-linearity in drug distribution. In case of drug metabolism, 2 points are there for causes of non-linearity. First is enzymes or cofactor saturation. When the enzymes or cofactors are saturated, then we will see this non-linearity. Example, alcohol and phenytoin. Then second point, enzyme induction. When the enzymes are self-induced, then also we will see this non-linearity. Example, the drug carbamazepine. Then drug excretion. The two reasons, the two causes of non-linearity in drug excretion are saturation of active tubular secretion, example penicillin G, and saturation of active tubular reabsorption, example glucose and water soluble vitamins. So these are the various causes of non-linearity in case of ADME, absorption, distribution, metabolism and drug excretion. So with this I have finished this video. Hope you have liked this video, and if yes, please press the like button and subscribe to my channel. If any doubts are there, please ask in the comment box. I will be replying to them. Very soon I will come up with the part 2 of this non-linear pharmacokinetics. Till then, stay healthy, stay safe. Bye bye.